just started recording.
Yeah.
No worries at all. Okay, it's live now, so you're welcome to start whenever you like.
Okay. Hi, good evening, everyone. So apparently I wasn't live and I was just talking. My name is Ayo. We're starting our first series of urological emergencies, acute scrotal pain. It's quite difficult to assess what the audience is going to be like. So I've made this initial topic quite general, and I'll be relying on your feedback to help us moderate the content. So please, at the end of this teaching, kindly remember to drop your feedback. Like I said earlier, my name is Ayo. I'm currently core training in West Midlands and I'm interested in urology. So we'll be starting with acute scrotal pain as part of our teaching series. And the causes and the objective is basically to identify the causes of acute scrotal pain, to properly understand the assessment of acute scrotal pain and identify treatment options for patients with this pain. It's basically an umbrella term. It's basically a constellation of new pain, symptoms, tenderness of both the scrotum itself and the intrascrotal content. It's quite a common presentation. And this presentation depends on wherever you're practicing your medicine. So if you're practicing acute surgical emergency on-call, you'd see it much more frequently than someone doing an unselected emergency. And if you are a urologist, it's probably going to be one of the most tedious parts of your on-call because of the decision-making needed. And as you would guess, it requires rapid evaluation and diagnostics. Just to talk about the relevant anatomy of what we're going to be studying. So we're going to be studying the scrotum and the intrascrotal content itself. And the scrotum itself is a fibromuscular bag, which is an outpouching of the perineum. It's covered by skin, subcutaneous dartos, and the extension of the anterior abdominal walls. The major nerve supply is split into two, anterior and posterior. So the anterior part of the scrotum itself, supplied by the genital branch of the genitofemoral nerve and also part of the ilioinguinal nerve, which explains why sometimes you can have pain radiating up to from the left or right flank to groin region. And you've also got the posterior branch, which is the perineal branch of the pudendal nerve and posterior cutaneous femoral nerve. Talking about the intrascrotal content itself, pain can arise from any of the epididymis, the spermatic cord, and the testes itself. The testes is as we know, is the region or is the area for for sperm production. It is covered adherently by the tunica albuginea, which is the fibrous covering of the testis itself, and it is overlaid or covered by the tunica vaginalis, which is like an extension of the peritoneum. In between these layers, you have small fluids which allow free flow of movement and prevents friction. The tunica vaginalis in itself covers most part of the testis, but doesn't cover the whole of the testis. It covers just the anterior and lateral part and leaves the posterior part for the attachment of the testis to the posterior wall of the scrotum. This attachment prevents the twisting and untwisting of the testis itself. In people with bell clapper deformity, instead of the tunica vaginalis to just cover just the anterior and lateral parts, you have it extending further towards the top of the epididymis and also most of the spermatic cord. And basically, there is no attachment to the posterior wall of the scrotum. So this allows for the testis to rotate freely on its axis, giving what is called a bell clapper deformity. The spermatic cord itself is an extension from the inguinal canal, from the deep inguinal ring all down into the scrotum. The walls are covered by the layers of the abdominal wall. The contents, you have got vessels in there, you've got veins, and you've got nerves in there. Carries the testicular artery from the abdomen into the groin, straight from the aorta. Also contains nerves and contains the vas. So all of these structures can be injured during testicular torsion. The etiology, most times, and most people, when you're on call and when you have to deal with testicular pain, the question running through your mind is usually, am I going to operate or I'm not going to operate? Because most other urological emergencies are usually clear cut. It's either an infected, obstructed system that you need to go to theater for, or It's either a urinary tract retention, which you need to relieve immediately. Testicular pain causes some kind of worry amongst practitioners deciding what to do and what not to do. So, in a way, to just say the etiology and also talk about quote unquote differential diagnosis for this, I've said to split this into three parts. So, ischemic or traumatic. So you could have torsion of the testes itself and or the testicular appendages. You could have testicular hematoma. The varicocele could be thrombosed, and you could have an obstructed inguinal-scrotal hernia. To we clinicians, it might be easier to delineate this, but for the patients, it's just scrotal pain to them. It could be infective or inflammatory. You could have epididymitis or epididymorchitis. Funnious gangrene has been slid in there, but really, funnious gangrene presentation is quite a little bit less dramatic than scrotal pain, and you need much more higher level of suspicion to actually diagnose funnious gangrene. Most of the patients in the early stages of funnious gangrene don't come with pain. They just come with some other non-specific symptoms and some skin changes on their scrotum. And because of the complex nerve supply to the groin and the referred pathways around it, you could have neuropathic pain actually. So mid-urethral stone, inguinal hernias, aortic aneurysms, which is quite important. Remember, the testes itself descend from the posterior abdominal wall into the groin, and it carries its nervous supply from the renal and aortic plexus. And there's nerve entrapments, the genital nerve, the ilioinguinal nerve, and diabetic neuropathy can also have some of this. Just to housekeep, if you've got any comments whilst I'm talking, just kindly remember to please use the chat box and drop them in. I'm going to have a look at them. Major topic for today is testicular torsion. Put a nice infographic there. I think it should be as clear. So it's basically the twisting of the spermatic cord, causing strangulation of the blood supply to the testes. It's as plain as it is. Twisting of the cord, causing strangulation of the blood supply to the testes. It's an absolute urological emergency. In the unselected population, occurs in about 1 in 4,000. And if you're to break this down much more specifically, I would say in every 160 men, one man is at least going to have testicular torsion before the age of 25 years. It's got bimodal age group of presentation, most common in the perinatal period, less than 1 year old, and in adolescents, so teenage boys are more commonly likely to have testicular torsion. There are a couple of risk factors for testicular torsion. You could have previous undescended testes, you could have you could have bell clapper deformity, you could have previous retractile testicles, like that. And one of the most important things to take away from today is that it's quite time sensitive. 6 hours is a golden time to save a testis from the acute onset of pain to when they present. Just a bit of anatomical variation and pathophysiology. Like I explained earlier, you've got the tunica vaginalis that doesn't completely invest around the testes, identified in this picture as just the blue covering, as you can see. And in perinatal period, less than 1 year, neonates, infants, usually, the testis is yet to fix at the posterior wall itself. So you can have twisting. So you have twisting of the old spermatic cord and the tunica itself. So the old testis is actually twisting. And this is almost exclusively seen in the perinatal period. The much more common one is the intravaginal torsion, where the fixation has happened and you have twisting of the spermatic cord itself within the tunica vaginalis. In those with this type, 12% of them usually have bell clapper deformity, and other ones could be usually due to spasm of the cremaster muscle itself, causing a violent twist of the testicle. So extravaginal, perinatal period, intravaginal, older people, adolescents. And how does this happen? Does the twist just happen immediately and you stop blood supply? So you have the twist first. It can go from as high as 90 degree to 720 degree rotation. So this twist causes a physical venous stasis and edema and swelling and increased hydrostatic pressure more than the perfusion pressure, leading to arterial ischemia. There's reduced blood flow, there's reduced supply of oxygen to the testes, and eventually infarction, and the sequelae happens. Because cells need oxygen, needs all of this before you begin to have reactive oxygen species and cell death happening. There's some time frame. This is why we say 6 hours. So the study of the textbook I've quoted has stated that from the acute onset of pain up to 6 hours, so the risk of orchidectomy, basically meaning the chance that the testicle is there, is only basically 5%, which is quite small. It rises steeply up to 20% in 7 to 12 hours, and almost categorically in pain that's persistent, not torsion, detorsion, persistent twisting. After 48 hours, 90% of the testicle is going to be dead. So, which is why we said time, and it's quite important. You see, many of us still go operate on patient after 6 hours because there's still a higher chance that the testicle could be saved. But after 48 hours, it becomes less of a rush. Clinical presentation, and this is where the meat of the matter is. And I think testicular pain is kind of one of the few standing pillars where history is much more important than investigations and all. The history differentiates the case for you, especially when you're on call, especially when you're in a place where you're not sure exactly what to do. The history in itself is very, very important to help us. I start with acute onset. So the pain is usually sudden, acute onset, severe, usually making them bend over, be sick, and actually feel like vomiting themselves. Sometimes they just feel nausea, sometimes they actually vomit. Pain is usually unilateral, though we say almost never say never in medicine, but the pain is usually unilateral because you have one side of the testicle actually twisting at a time. Part of the important things to check when you're asking about the pain is the onset of the pain. As you know, it secretes the pain. Ask for the character, the radiation, the exhibiting factor. Ask what they were doing. So they could either be sleeping, they could be walking, they could be running, it could be during sex, it could be traumatic. So there's so many causes and there's so many things that can predispose twisting of the testicle. Part of the important things in the history is to ask if the pain has remained the same since the onset, or does the pain come and go? You just basically want to know if it's twisting and detwisting, because you can have torsion detorsion syndrome. You want to know if they've had this pain before in the past. How many times have they had this pain before in the past? Asking about the pain itself, ask if they've had any procedure done in the past. Have they had any troubles with their testicle in the past? Have they had the other testicle removed, really? Did all of these answers help you weigh how much risk and balance you have to decide for what to do? You need to ask for associated symptoms. You need to know if there has been any fever, any urethral discharge. You need to know about their sexual history. You want to ask them if there's any color change on their testicle, any rash, any bump, looking for Fournier's gangrene. Also important to ask for medical history in these patients. Are they diabetic? Are they on any immunosuppressive medications? You need to ask them, do they do any heavy lifting? Does this pain come and go? Because you need to rule out common causes. If we remember the things we've said earlier, so do they have a hernia? Are they having pain from anywhere else? Any abdominal pain? Any feeling unwell? Basically trying to check for other much more sinister causes. For examination of this patient, it is an intimate examination. Always remember to maintain this patient's dignity. And so always offer them chaperone, even if you're male or female, offer a chaperone for this patient. And you need to examine both the abdomen and also examine the genitals itself. I usually prefer to examine their genitals first before I examine the abdomen because it helps me make up my mind. You can have a look at the testes. So do the IPPA. So you're not going to auscultate the testicles, but it's still quite important. So inspect, look for any swelling, check out the lie itself. You can have a look and see, does this look straight or does it look like it's lying sideways? When you say high riding testes, the left testes usually lies slightly lower than the right, but if there's torsion, it's going to be extremely high up, almost like it's going into the groin. You need to check for any skin changes, any redness, any scarification, any signs of previous surgeries. All of this is helping you make up your mind on what exactly you think is going on with this patient. If there's a swelling, try to see if this swelling arises from the groin or if it arises from the scrotum. And tell the patient that you're about to examine them. Usually start from the non-painful side so you can appreciate what the normal anatomy is for these patients. So you need to touch the testes, feel for warmth, if there's any differential warmth. It might be difficult to differentiate from epididymitis with the warmth or not, but you need to check if there's warmth. You need to palpate the testicle itself, stabilize the testicle in one hand and palpate it in the other hand and check for tenderness, check for any hardness, check for masses, and see if there's any swelling over or tenderness over the epididymis. The epididymis in itself tends to be much more tender, even when it's normal. So try to touch that area last so you don't make the patient uncomfortable. And usually you're able to tell if the patient is tender or not. Touching the testicles for most patients is quite an uncomfortable feeling, but you're able to distract them and speak with them if this pain is not really that serious. The French sign is not really as reliable as the textbooks say they are. So French sign is basically when you elevate the testicle, you should have some pain relief. If there's no pain relief, it's most likely a torsion. If there's some pain relief, you think of an infection. But you find that it is equivocal in most times. An absent cremasteric reflex, which is basically stroking the inner thigh of the patient, trying to see if we can activate the cremasteric arc and get the genital branch to get the reflex activated and see if it can cause contraction of the cremaster itself. And this contraction allows you to see like the squeezing and rising of the testicles when you do that. Make sure you complete a full abdominal exam. Check for inguinal hernias. Check for inguinal-scrotal hernias. Check for cuff reflexes. Probably palpate the abdomen. Check for any swelling. Check for any palpable bladder. Check for hard masses. Also important in some cases in older men, to do a PR, you need to look for a large prostate. You need to see if there's any constipation in there. And finally, see if you can palpate for any expansor abdominal mass in thin patients and listen for bruit over the abdomen, which is where you need the auscultation for. Basically, you need to rule out an abdominal aneurysm, especially in older men. By the end of this examination, you're beginning to have an idea already, actually from the history, acute onset, pain in the testicles, tender testicles. You're more likely than not beginning to start thinking about torsion at this point, and you need at this point to begin to organize some theater time for this patient. Because of how subjective pain can be, the twist was initially made for the pediatric population, for one, non-experienced clinicians and also non-clinicians, to help them to differentiate if a child has torsion or not. But it's now been validated for adults and for use even amongst physicians. So it got criteria: high riding testes, absence cremasteric reflex, nausea and vomiting, swelling of the testicles, and hard testicles. 0 to 2 is low risk, is likely it is not torsion. 3 to 4, it all depends on the pathway, your local pathway. If you have an ultrasound that is available that doesn't delay your diagnosis, a Doppler ultrasound might be helpful here. Or greater than 5, absolutely need to go to theater. In most centers, their theater was just going straight to theater once the patient takes more than 2. It has 100% positive predictive value. So patients with scoring more than 6 points definitely have a torsion. 90% of those still high enough in those more than 5 have a torsion. It has a negative predictive value of 100% in people with less than 2. So this is quite helpful. Helpful for you, helpful for your documentation, helpful for the patient, and helpful for medical legal purposes. And you've got a way to score this patient and risk them, helping your decision making. So management, as always, mainly by history and examination, really can't stress this enough. By the time you're speaking with the patient, before you even touch the testes, sometimes you already begin to think, I think this is torsion or not. For most urologists, the problem deciding, is this torsion, is it an infection, especially in that age group where they're not really children and they're not really more than 35. So really the young adults, it's usually very difficult to make up our minds on what to do. But this gets better with time as we see more and more of them. So it's an emergency. So always remember to resuscitate the patient ABCD, make sure they're stable, give some pain relief. Adequate pain relief is important. We don't score points for saying, oh, I need somebody else to come examine, though I'm not going to give them pain because I don't want I don't want the testicle to not be painful by the time they come. If your history is suggestive and your examination is suggestive, even if you need a second opinion, it's right to give this patient some pain relief so they can feel better and much more comfortable, really. Bedside investigations, so urinalysis, check your urine dip, check for any blood in the urine, check for any signs of infection. All of this doesn't mean it is not a torsion, but it helps to tie all the story together if you're thinking of an infection or if you're thinking of a torsion. Also go to send off some urine MCS if you're suspecting some infection. You do regular bloods. Most times bloods are routine and not needed for testicular pain, especially the ones that sounds like torsion. And ultrasound, Doppler ultrasound is the gold standard of management. It's a gold standard to decide if somebody has testicular torsion or not. But more often than not, your diagnosis and your treatment is delayed by this. So if Doppler ultrasound is going to delay your treatment, is going to delay your diagnosis, I think the first thing to do is explore and decide afterwards. In some centers, very few centers, they've got Doppler ultrasound right there, and they can do it for the patients. But this is not often the case. As soon as you're making your decision that it's a torsion, escalate appropriately. If you're a junior, escalate to more senior colleagues. You need to go to theater, so inform the theater team, inform the anesthetist. It's category 1, so it's organ saving, so it's as soon as possible. And the surgical management, of course, is the ultimate treatment. A couple of discussions about this surgical management. Surgical management is scrotal exploration. But what are we going to explore? What do we tell the patient? To the patients that are going for surgery, to the physician deciding what to do. As a baseline, when consenting and booking the patient or speaking with them, so at the minimum, we are doing a unilateral orchidopexy plus or minus orchidectomy, depending on the viability of the testicle, and we are doing a contralateral orchidopexy. The contralateral orchidopexy is a point of various discussion amongst several urologists because you need to decide what to do for the testicles in theater. We know if it's torsion, we need to take them to surgery. We know to have this surgery done. But usually what is done for fixing this testicle is usually what the question is. And that's where most debates come about, really. What to do intraoperatively. Most people do a midline scrotal raphe incision, and there's a small group of people who do a transverse incision. There is no scope for a paramedian unilateral incision. Doesn't help with exposure, doesn't help the patient. The cosmesis isn't really considered down there, but also doesn't help with cosmesis. When we are consenting this patient, it's good to talk about risk of pain, chronic pain, infection. It's almost impossible for a torsion to happen on a fixed side again, but you need to say there's a small risk of testicular atrophy, there's a small risk of infertility, though this has not been validated, but because of various breaking the barrier, you can have some autoantibodies which affects the sperm production. But all of this are just projections and you've not had a concrete cause, but it's good to let the patients know when you're consenting them. And sometimes it's good to discuss with the parents because many times we are consenting children, not to let them know that it doesn't cause infertility, it doesn't cause testicular atrophy, but these are risks and these are things that they should be aware of just in case. So going forward and talking about what to do intraoperatively, I'm sorry, this flow sheet doesn't seem to be as clear as I thought it would be, but it's from a consensus document. So I currently work in the UK, so it's a consensus document from the urology trainees and the urological consultants. So that's Boston Boss, and they've had a discussion and a very wild approach on what to do when you have testicular pain. So clearly, when you explore, if torsion is confirmed, so torsion confirmed on one side, and if the testicles appears viable, so you've opened up the patient, you can say, oh, this was twisted, you've untwisted the testicle, and the testicle appears viable. So on that side, testicle is viable. So untwist that and fix the ipsilateral side. Because you have a confirmed torsion on one side, it is important to go over and fix the other side. So when we say fix, so I mean 3-point fixation, usually with a permanent suture and usually with a monofilament non-braided suture to decrease the risk of infection. So you find many people use Prolene for this. So 3-point fixation, you can do medial, lateral, and just the base and the apex itself, so just to tie it down. Testes appear ischemic. You untwist it, torsion has still be confirmed, but testicle doesn't look viable. So you untwist it, you apply warm saline-soaked gauze. Some people say ask the anesthetist to give 100% oxygen, but that's really up to the surgeon. But most people still ask them to give 100% oxygen, really. Wrap that in warm gauze. The next question is, how long do I wait before I decide if it is ischemic, if it is viable, if it is non-viable anymore? So it appears ischemic, wrap it up. Most people say the time it takes to explore and fix the contralateral side is enough to see if this testicle is viable or not. So it depends on how fast you are. So you put 10 minutes, so you put more than 10 minutes. Fix the other side, then go back to the testicle itself. This is quite important. So by the time you're done with the contralateral side and you have a look at the ipsilateral testicle, if it appears viable, just fix it and close up. If you're not sure that this isn't viable, consider a stab incision on the tunica albuginea to see if there's any bleeding. If it is still uncertain, just fix the testicle and close it back, and you can do serial ultrasound scan to see what that testis is like. If the testis appears unviable, unfortunately, an orchidectomy has to happen. In most cases, when this has to happen, you need a second opinion. So you find most registrars letting their consultants know that, oh yes, we are going to, we need to take out this testicle, and that's going to be done. So you do a scrotal orchidectomy for this patient. That's quite clear if there is a torsion confirmed. We begin to have different types of school of thoughts when we have no torsion and you have no other pathology seen. So you've opened up this patient. The testicle doesn't appear twisted. When you open it, it doesn't look like there has been any twisting. So you've got no reactive fluid, no redness whatsoever. Okay. And you examine the testicle. The tunica vaginalis itself doesn't look like a bell clapper deformity. This consensus document states, replace the testis. Don't perform a fixation. That's what it said. But all the time I've seen testicular torsions happen, even when we open it and there's no pathology. We're there already, so we just fix it and close still also. No bell clapper, fix and close. But the consensus document, especially for more junior doctors, is good to follow guidelines, really. Just replace the testicles and close, don't perform a fixation. If a bell clapper deformity is seen on one side, you fix that testicle because there's, of course, a very high risk of it retwisting again. You don't want them to come back. Though it is said that because of the fibrosis from recent surgery, the testicle should fix itself, but it's usually still good to fix it. And because you've seen bell clapper on one side, it's good enough to explore the contralateral testes. If there's no bell clapper deformity, also it says just replace, but you're there already, so most people just fix too. And if you can see it on one side, clearly fix. So basically clear, bell clapper, fix, no bell clapper, don't fix. No torsion, but you can see other pathology present. So you open it, no torsion, you can see a dotted cyst of Morgagni there, or you can see that there's some epididymitis and some inflammation, and there's lots of reactive fluid without any sign of torsion. So, and there is no bell clapper ipsilateral. So it says replace the testicle, close, and address the other pathology. So take out the dotted cyst and close. This document says close, but most people, they're already in the testicles, they fix. But we are just following what this document says. And I'm sure, given that we have different backgrounds we've got different local guidelines on what to do for this, it would be nice to drop them in the chat so we can see what people do in their centers. If you see bell clapper, ipsilateral, fix that and address the other, plus or minus address the other pathology. If clearly you can see an infection, just close it. I mean, I think that's quite clear. So some people do actually fix. You can clearly see that this is epididymal orchitis. Just close it. You also don't want to be poking into the tunica albuginea when there's an ongoing infection. So those are one of the few times that people just close back, actually. Pathology other than epididymal orchitis, they also decide to explore the contralateral testes and address other pathology. All of this begins to go into the field of deciding on what the surgeon wants to do. But this document is very, very, very nice. It helps solve lots of questions and debates. You can just Google the BURST and BOS guidelines for this. It's going to be very helpful, really. I thought I had a summary document. So going back to epididymitis, which is just basically That's the next common one. So I've talked about the ones where you most likely go to operate, which is torsion. These ones you don't really, you're not going to operate, and this is what most people need to make up their mind. Unfortunately, epididymitis is far more common than torsion. So if you say 10 testicular pains, more likely than not, 7 or 8 of them will be just epididymitis. It's either an inflammation or an infection. Excuse me, in older people is more likely to be an infection. In younger people, though, you need to be very, very confident and really experienced to diagnose epididymitis in a young child, usually caused by repetitive action, jumping, playing around. You have the epididymis itself inflamed. Is the most common cause of acute scrotal pain in adults, as I've explained, and usually seen in increased age. So you can see, for example, if you're on call, you hear, oh, a 60-year-old man has come with testicular pain. You don't react the same way when you hear, oh, a 15-year-old man, boy, has come with testicular pain. That kind of already says how frequent we think it is. And the management itself depends on the likely etiology. Usually we give antibiotics or antimicrobials depending on the cause. And once again, history is a differentiating factor. Really slow onset. You have this niggly pain that's been going on for a couple of days. They feel unwell. They've got some fever, some urethral discharge, and sometimes they've got skin rash because associated with an STI. It could be unilateral or bilateral. They could have some swelling. Place feels a bit warm. They feel quite unwell in themselves. Men less than 35 years old and sexually active, I think is more likely to be due to an STI. Though it can still be from bacteria, from gut bacteria, but we likely just think just a way to differentiate it. Either it could be chlamydia or gonorrhea. For men older than 35 or those not sexually active, we begin to think about gram-negative urinary pathogens. So E. coli, Klebsiella, Proteus mirabilis. When taking our history, it's important to see what medical conditions they've got. Are they diabetic? Ask about sexual history, any immunosuppressive medication. Have they had this before in the past? Have they had any recent instrumentation into their urethra? Both medical and non-medical instrumentation into the urethra. Have they got issues with their bladder? Have they, because sometimes you can have reflux urine into the epididymis causing this kind of pain? Have they got any previous TURPs, or are they taking current medications for this? And ask about bowel opening or constipation too. So medical conditions and sexual history are quite important. Examination itself, you need to do a scrotal and abdominal exam, similar to a torsion, occasionally difficult to differentiate, but you find them much more unwell. You find the swelling much more pronounced compared to a torsion. In some cases, you could be thinking they've got abscess ongoing there. The skin might not look normal. The skin might look red, painful. In these cases, also have a very good high index of suspicion for what is called Fournier's gangrene, which is basically necrotizing fasciitis of the groin, the skin around the groin and the perineal region. Doesn't really typically present as acute scrotal pain in itself, usually much more trickier to diagnose. You find them complaining of some small swelling around their groin area, some blackened area. Usually they're diabetic, large on the high BMI area, poor perineal hygiene, previous medications, kind of help you to differentiate that. And it's really easy to pick up, really. Friend sign, pain on relief in the testicle. Up to 30% of patients will have this sign. Doesn't mean they've got torsion or not. And also, cremasteric reflex may be absent. So the question is, how do I really differentiate if this is torsion or not? 1, experience. 2, multiple examinations. 3, use of twist score. And 3, local guidelines. For example, where I currently work, if you're a child and you walk into the department with testicular pain, even if the history is going for more than 12 hours, you are going to have a scrotal exploration happen. It's a bit different from some other centers where you have to consider cost to the patient, cost to the system too. But it's just good to have that at the back of your mind. Considering scrotal pain, our decision is really, is it a torsion or is it not a torsion? And most people will like to, as you say, go on the side of, oh, I think it's a torsion and I need to explore. Management, resuscitate the patients. They could be quite unwell, so do a complete sepsis screen, take some blood cultures, full blood counts, a urine dipstick, MCS, do a complete urethral swab, send some samples off to the sexual clinics, do full bloods for them. They may need ultrasound because we're thinking more of epididymitis. You want to see if there's an abscess in there, especially when it's big. If they've got other comorbidities, you need to consider, do they need BMP? Is this scrotal edema? You want to check, you want to see if they need echo, if their history and their clinical presentation suggests that. Antibiotics depends on local guidelines. If you're thinking of an STI, you give them antibiotics for STI. If you're thinking it's one of the ones from the groin, you give them proper antibiotics. For young patients, it's good to refer them to sexual health clinics where they can have full screening of this and decide what exactly is going on. And in summary, we've just talked about acute scrotal. Remember, the causes are broad. It could be both abdominal and scrotal. It could be long-standing, and it could be very acute. In younger children, we're much more worried. Time is golden, so we're faster. The most important thing, investigations should not delay. They're quite academic, but investigations should not delay both the diagnosis and the management in itself. And if in doubt, kindly always explore. I think that's the end of the presentation. Thank you. If you've got questions, I'll take the questions now, or you can drop them in the chat. I can see Dr. Martin is around. If you've got something to add for us, something that we have missed, that'll be very helpful too. And if you also have anything to add, you can either add them on the chat. We can all see it or just speak up. Thank you. If there are no questions, if there are no suggestions, it's either I have just succeeded in saying lots of what's the word again? Things that we know already and just repeating the same thing, or I've just confused everybody. So some contribution would be very helpful. Some other question I was going to ask is that do we think clinical scenarios might be better ongoing rather than just do didactic lectures, give some clinical discussions, and so we can discuss about that. This is helpful. We're all in the formative period, so it's good to just see what method works best for us, really. Thank you very much. I think if there are no questions, no further contributions, just please kindly remember to fill the feedback. That's going to be very helpful to help us to improve these teaching sessions. Also helpful to decide what kind of topics we need to bring in and help us as a group. Also, and you also get certificates that you attended this. I think I'll leave that to the admin to try to allow people to do feedback. I'm trying to do it from my end, but I don't think I've got that done. So if you've got no further questions, thank you all or no questions at all whatsoever, unfortunately. Thank you all for coming to this first session. I think the next session will be either in a couple of weeks' time, but we'll have lots of notice beforehand. Thanks a lot, everyone.